Good afternoon and welcome. My name's Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the UNC Lineberger Comprehensive Cancer Center. And it's April 27th, 2018. We are thrilled to have you here for today's Community Lunch and Learn lecture. A few things before we get started. If you're having any technical difficulties at all, now would be a great time to call our team at 919-445-1000. Let us know what's going on, bad audio, bad video, whatever. We have multiple ways you can join our presentation, and we should be able to figure this out so that you have a great experience today. This will be recorded as well, and we'll make that available both in our learning portal and in our online library and on YouTube. We hope that you enjoy the lecture today, and we hope that you'll share links about this with your colleagues as well. All right, we're on Facebook, we're on Twitter. Best place to find us is usually unccn.org, where you can find out about future events, past events, our library, all sorts of other things as well. With that in mind, let me go on and talk about our polling. So we use Poll Everywhere, and we hope that you will participate in our initial poll, and then we hope that you'll be using Poll Everywhere to submit your questions to our presenter during today's presentation. Two ways you can join Poll Everywhere. If you've got a web browser, or whether that's a laptop computer, a desktop computer, the browser on your phone, you can just go to pollev, pollev.com/UNCCN, and you're there, you're in. As you see, as we move from the poll question to the Q&A, that will automatically refresh on your computer, and you can go ahead and submit your poll answer and submit your questions there. If you would prefer to use texting, you can do that as well. You can do that from a smartphone. You can do that from a phone that's not so smart, as long as it has texting capabilities. And so you start off in that 2, just like I'm showing on the slide here. In that 2 field, you put in the number 22333, and in the message field, you put in UNCCN. Send that, you'll get back something saying joined, and then you can go ahead and submit the letter that corresponds with the answer for our first question, and then just text in your questions when the opportunity comes up later in the presentation. All righty, so there's what it looks like. This is our poll for today. Which of the following is not a benefit listed by the American Cancer Society for palliative care given to patients with cancer? So pay attention to this. This is which is not a benefit, and would it be A, have better quality of life, less pain, less shortness of breath, less depression, and less nausea? So if you think that's the answer, put in an A. If you think it's have less severe symptoms, you would put in B. If you think it's less likely to be readmitted to the hospital after they went home, you would put in C. If you think its medical care tends not to align with their values, goals, and preferences, you would put in D. Or spend less time in the intensive care units, that would be E. So if you'd send in an A, B, C, D, or E, and this is anonymous, so we're not going to link this back to you, but make your best guess on what the answer would be, and then we'll look at that in just a moment. So with that in mind, we want to go ahead and welcome our guest today, Dr. Dellon. Thank you so much for being here.
Thank you. It's great to be here.
Well, let's see. We've got our bio up on the screen for you. Let's see if we got this right. You're a professor of pediatrics at the UNC School of Medicine. And how long have you been with the School of Medicine?
I have been here coming up on 14 years.
Great.
Yeah.
Great. All right.
So I'm a Tar Heel now.
You are a Tar Heel. Where did you come here from?
I am originally from Minnesota, and
Great.
I came here by way of Boston.
Great. Okay. Well, we're glad to have you here. Pediatric pulmonologist and palliative care physician. Direct the Children's Supportive Care Team, which is the Pediatric Palliative Care Consult Service at the NC Children's Hospital. And your interests in pulmonology and palliative care come together both in your clinical practice and through your research. Mm-hmm. And feel free to let me know if I've got any of this wrong, because sometimes we pull up information that's out of date or not quite right.
All correct.
Okay, good. We're doing okay so far. You're currently investigating the feasibility and impact of early palliative care education in cystic fibrosis care. Mm-hmm. And your palliative care practice extends beyond children with pulmonary diseases to those with any serious illnesses including cancer.
That's right.
Okay.
Yeah, we see any child with palliative care needs.
All right. And what did we leave off? What are two things we should know about you that weren't on the list here?
Well, let's see. That's a tough question. I'm also a mom.
Great.
I have two little girls who are fantastic, and a husband who's a gastroenterologist here at UNC.
Okay.
And another thing to know about me is that palliative care is really my passion.
Mm-hmm.
I'm very passionate as well about pulmonology, but I think I kind of found my heart in palliative care. One of the nice things about palliative care is that learning and practicing it contributes to everything that you do in your career. Yeah.
Well, we're looking forward to finding out much more. So let's take a look at our poll and then let you get started on your talk. How are they doing?
They're great.
Okay.
You got this, guys. I'm done.
Okay, you're set. Yeah, they got it. No, well, good. I'm glad. And now hopefully all of you are comfortable with using that tool. You didn't have to answer that question to do the Q&A later, but we're glad that some of you were able to get in and do that. Thank you again all for being here today. And without further ado, addressing palliative care needs of children with cancer with Dr. Dellon. And let me pass the controls over to you.
Great, thank you. And I'll try not to mess them up.
No, you're good.
So it's great to be here. We will be talking about palliative care, but really focusing on pediatric cancer today. So our objectives for the talk, just kind of loosely, are to define pediatric palliative care. What is it? What does it mean? Who is it for? We're going to work on understanding specific palliative care needs of children with cancer. And we'll also consider the roles of the oncology team, palliative care specialists when we're involved, and other supports in providing palliative care to children with cancer, because medical care for anyone with serious illness really takes a village. So first, what is palliative care? You may have heard lots of different things about palliative care. You may be very familiar. It may be a completely unfamiliar term. But very kind of briefly and succinctly, palliative care aims to prevent, identify, and treat suffering in individuals with serious illnesses and their families. Palliative care can help with many things, and I want to kind of use these 4 bolded points and take them with us throughout the presentation. It can help promote effective communication between patients and families and healthcare providers. It can ease pain and other symptoms, both physical and emotional. It can help delineate goals and hopes for one's cancer treatment in the case of cancer, and can support decisions about medical care at any stage of the disease. One of the key takeaway points from today is that palliative care is really appropriate at any stage of illness, and it can be provided along with treatment that's directed at controlling and curing disease. We're going to get into that a little bit more. I like to think of palliative care as coming alongside curative treatments, or restorative care is another, word that's helpful, especially for conditions like one that's very close to my heart, cystic fibrosis, that doesn't currently have a cure. But restorative care is care that's intended to preserve someone's baseline health. So if you look at this figure, I'll try to use the pointer without screwing things up here. On the x-axis, we have time. So from the onset of symptoms of disease or diagnosis, all the way through end of life. And on the y-axis is intensity of care. And the bold line here, the dark line, is curative or restorative care. So these are the treatments intended to cure disease or to maintain a baseline of health. Alongside that can come palliative care, and that's the dashed line. And you can see that with time, depending on where someone is in their illness course, the intensity of treatments, both curative or restorative and palliative, can wax and wane. In the case of people who will ultimately die from their disease, palliative care ultimately kind of surpasses curative and restorative cares when we're really focusing on comfort and quality of life. And for patients who are expected to die from their condition, hospice is a part of care that can be appropriate and desired by many people. After death is a period of bereavement for the loved ones, for the community around the person who dies. And palliative care actually includes bereavement care as well, and we'll touch briefly on that later on. So again, just want to reiterate, and I like this quote, that palliative care really isn't about dying, it's about living, living with serious illness. And this quote from a 17-year-old with a terminal illness, I think, really describes it nicely. Palliative care no longer means helping children die well. It means helping children and their families to live well, and then, when the time is certain, to help them die gently. So I just want you to take that with you as we think about what palliative care is. So in childhood cancer, I wanted to talk a little bit about the why palliative care, when palliative care, and who is appropriate for palliative care. So just some kind of background information. Childhood cancer is fairly prevalent, about 12,000 new diagnoses each year in the United States. And fortunately, at this day and age, it has about an 80% cure rate, which is really remarkable. Unfortunately, though, many children still do die from cancer, and there are about 2,000 cancer deaths in children each year in the United States. We know that physical and emotional symptom burden can be high, even for children really with lower risk cancers, and that can be the case throughout the course of illness. We also know that for any individual with cancer, prognosis really always is uncertain. There are many cancers that we expect someone will survive and will be cured from or can be controlled, and unfortunately surprises can happen. Along with that, and on the flip side, sometimes we think that it's very unlikely that someone will survive their cancer, and they are cured, which is always wonderful. But we know that because of this prognostic uncertainty, that we have to really be respectful of the fact that goals and decisions that people make and have for themselves can change with time. A little bit more on the why, when, and who. So there, again, is a common misperception that palliative care is just for people who are dying. We know from clinical practice and from research that early palliative care for people with cancer has a lot of demonstrated benefits, and in fact, it's endorsed by multiple professional organizations. There's some very clear statements, and you can find a lot of these online, these professional societies. Early palliative care, in fact, has actually been associated with increased survival in advanced lung cancer, and similar studies haven't been done in other oncologic processes, but was really a very striking finding of the first real clinical trial of early palliative care in an advanced cancer. People actually lived longer when they had early palliative care interventions. So who is really appropriate for palliative care, and when should they get it? Is kind of a big question and a hard one that we all struggle with, even as providers, identifying who's appropriate for palliative care. So I'm going to bring you back to this diagram that I showed you, initially thinking about time and curative and restorative and palliative care kind of riding together, and then I'm going to not really superimpose, but kind of flip to a slide that has some descriptive words that I think might be helpful. So the blue box is kind of during that treatment phase, from diagnosis through active treatment, where there's individualized blending of care, directed at underlying illness and the emotional, physical, social, and spiritual needs of the child and family, with continuous reevaluation and adjustment is as necessary and appropriate. When it becomes evident that somebody's not going to survive their disease, there's this period of end-of-life care. Throughout diagnosis, active treatment, and end-of-life care, there can always be hope for a cure, for life extension, and for a miracle. And many, many of our patients hope for all of those things up until the very end of life. Then that period of bereavement care that we talked about, and it tapers off because with time we hope that people's grief is becoming more manageable and that their resources have been helpful and that they're allowed to sort of resume more normal life activities without their loved one. But throughout the entire period, there's hope for comfort and meaning, and the legacy of someone who has died often provides a lot of comfort, and people find meaning in the life of the person who unfortunately left them. So, taking all of this into consideration, truly, palliative care is appropriate for any child with cancer who's having distressing symptoms, considering goals for cancer care, and or facing decisions about treatment. So pretty much anybody. And just to reiterate, it should be available at the time of diagnosis until it's no longer needed, either because someone is cured or because they die. So I want to take these sort of themes again. We talked about communication, we talked about symptoms, we talked about goals and decisions. So I want to look at symptoms. This very colorful bar graph is from a paper published by Dr. Joanne Wolfe at Boston Children's Hospital and Dana-Farber Cancer Institute back in 2000. It was really a landmark study looking at symptoms in children, and I should have put in the title, with advanced cancer. They surveyed parents after children died and also looked at the medical records of children who had had cancer and looked at what the symptoms were as they experienced them, both through the medical record and through parents' recall. So the blue bars are whether or not the symptom was reported, and you can see that fatigue, pain, shortness of breath, poor appetite, and nausea were all very common. Whether or not the child suffered from the symptom was a subjective question asked of the parents, and you can see in the yellow bars that there was a fair amount of suffering related to many of these symptoms. They also looked in the chart to find out whether the symptom was treated, and you can see that pain was treated very often when it was reported. Shortness of breath quite often, but some other symptoms like fatigue, poor appetite, and nausea really weren't treated very often. And what was really concerning about this was looking at whether or not the treatment was successful, and that's what's in the green bars. So again, this is children with advanced cancer, but we know from subsequent studies from this group and others that throughout the course of cancer treatment, many children have many of these symptoms and more. And I think we're doing better at treating them, and certainly cancer therapy protocols include a lot of symptom management, even if you don't do it beyond what's in the protocol, but we know that we have a long way to go. So goals and decisions were a couple of other big themes, and just briefly, cure is very often, pretty much universally, the primary goal, right, especially at the time of diagnosis, and often remains the primary goal even until someone dies. It's just our basic human hope that someone will survive and will be free from illness. At the time of diagnosis, when we think about decisions, the choices really might feel very limited because, there are protocols for treating most cancers, and you sort of, this is the plan, and we will pick the right chemotherapy regimen and surgery if it's indicated, or radiation if it's indicated. But those decisions become more complicated, and often the choices change if cure is not achieved. So things like relapse or disease progression can bring about decisions about more surgeries, about different types of chemotherapy, radiation. For some cancers, things like bone marrow transplant, which is a huge undertaking. Experimental therapies or research protocols, sometimes actually leaving your home center, moving even out of state for therapy that we hope will extend life meaningfully or lead to cure. So it gets more complicated, and because of that, it's important to establish a framework for decision-making early on. The model for decision-making for cancer or for any complex illness is really a shared decision-making model where the patient and family and healthcare team are partnering to make decisions together. This is typically how we try to practice. It can be challenging for a lot of reasons. But regardless, we should be emphasizing aligning goals with decisions and recognizing that those things might change with time. Okay, so laying a little bit more foundation for palliative care, I want to bring up something that I think is an important aspect of care of any illness, which is kind of concurrent goals of care. So we often think of cancer-directed therapy as being kind of mutually exclusive from intensive symptom control, and that may sound a little crazy reading that line, but as an example, when we think about the culture of cancer is often sort of fight cancer and stomp out cancer, and if we're really aggressively treating pain, we worry about medications that we're using and side effects of medications, and we're worried that if someone's having a lot of symptoms that cancer is actually winning. And so it becomes difficult to kind of hold both of those things, and I don't like the word aggressive, but intensive cancer therapies and intensive symptom management often feel a little bit disparate. We know, though, that both the underlying disease, the cancer, and the therapies for it contribute to distressing symptoms. And in fact, in the literature, we've found, and in clinical practice, we know that suffering from physical symptoms actually diminishes as the disease is controlled, which makes sense, but also as cancer therapies become less intensive, either because the cancer is responding to treatment and we're backing off, or because we're choosing to back off because the disease is progressing. In advanced cancer, we know that milder cancer treatments, while ongoing, can be very important to people, are associated with improved psychological well-being in the last 12 weeks of life, so kind of getting at those emotional symptoms as well. So, it seems a little bit obvious, but in clinical practice it can be tough to think through this. Parents may favor, and children of course may favor and benefit from blended goals of care, and really what this means is continued efforts at disease control plus intensive symptom control. And really this is kind of where palliative care is and can make a difference, I think, for children with cancer. So who does this, right? Oncology teams are amazing, and they do provide a lot of palliative care. So this is a little schematic of the patient and family kind of at the center, and then a whole bunch of people that might be involved in the care of a child with cancer. And they may not all be involved in every child, but for some children, it's literally everybody in this circle and more. So when we think about the primary team, in this case, the oncology team, really what is their role? So we know that cancer care is really team-based, and here's our adorable team of doctors and nurses and psychosocial providers. And I've listed on the right side kind of often who those team members are. So the oncologists or oncology practitioners, nurses, there are psychosocial clinicians like social workers and psychologists, sometimes psychiatrists. Child life specialists are really an important part of the team for children, for working on coping with illness, trying to find meaning in what the child is experiencing and trying to maintain some normal activities of childhood. And then pastoral care, spiritual care providers can be really critical to supporting spiritual needs, and those are really different for every person and family. So what does this team actually do? Palliative care is really a routine component of cancer care, and it should be offered by the oncology team, and typically, of course, it is. So what do they do? There's a really nice paper that many of us have used to kind of think about delineating what are the primary teams, kind of what is their role in providing palliative care. So what are the kind of primary palliative care skills that an oncology team with all of its members of different disciplines should be able to provide? So those include things like basic management of pain and other physical symptoms, basic management of emotional symptoms, basic discussions about things like prognosis, goals of treatment, suffering and the experience of illness, and also wishes around life-sustaining treatments. If someone has a life-threatening event, how are we going to intervene? So oncology teams may be able to provide all of this and more, and they often do. So who else provides palliative care? Again, looking back to the circle, many of the people in this circle, in fact, probably all do in some ways, but we're going to look a little bit at what palliative care specialists do specifically. So palliative care is also team-based. So we have the same adorable group of providers that include basically the same types of people. Now, depending on where you are, some of those roles are not actually present, or some of those roles are borrowed from other specialties, from sort of the general inpatient units in the hospital, from the oncology clinic, right? So we may be partnering together with the child life specialist who works with kids with cancer, who's not a part of the specialty palliative care team, but works with the specialty team as part of their job. So the role of the palliative care team specifically, really, palliative care specialists, they focus on quality of life and are available to address concerns that are kind of beyond the scope of primary palliative care, or that add and fill gaps. So these skills would be things like management of refractory pain or other complex symptoms. We see a lot of symptom clusters in people with serious illness, so trying to tease out how best to approach really complicated symptoms that are causing a lot of distress. Managing more complex emotional symptoms, depression, anxiety, grief, and existential distress and suffering, that kind of, why me, why my family, the crises that people experience when they're sick. And also assisting with conflict resolution around goals or methods of treatment. So these might be differences of opinion within families, and we see a lot of teenagers who maybe feel differently than their parents, or one parent feels differently than another. Often there are conflicts between staff and families, or among treatment teams, because there are a lot of cooks in the kitchen, and sometimes one team feels differently about the right next step versus another, and patients and families get kind of caught in the middle of it. What's not on here is also, I think, important, which is some of the ethical dilemmas that come up around care that we worry may be causing more harm than benefit, kind of working through some of those issues. So I want to think about palliative care now that we've kind of introduced like what the cancer care team does, what the palliative care team does. It's probably about clear as mud, but I'd like to actually think about palliative care provided by anyone involved in the care of a child with cancer at different stages. So going back to that diagram, we're going to look at, what are the palliative care needs and how do we do this at diagnosis? What about during active treatment? How about when there's disease progression or relapse? And how about at end of life? So before we get into this, I'm wondering if anybody has any questions, and then we will do a case example.
Great. And Dr. Dellon, I've got a whole list,
I
so
you were right.
I'm going to try not to hog the question time here. So please, we want our entire audience to be sharing their questions as well. And yours take precedence over mine, but while we're waiting, I'll ask a few. Tell us more about this notion of meaning, and you talked about the child life specialist. Obviously, in some ways, this feels incredibly meaningless that for anyone, especially a child, to be struck by cancer.
Yeah.
What are some of the strategies that the child life specialist or others are using to find meaning in this really difficult time?
Absolutely. So I think what the child life specialists do is help children find their voices in cancer treatment. So there often is a lot of existential distress. And of course, it's different at different ages, right? Like a really young child may not have a great sense of what they're going through versus an adolescent who this is tremendously impacting their lives, and they're angry and they're frustrated and would like to do anything but be dealing with this. So helping children find their voices, helping them participate in their care in a meaningful way, helping them cope with anxiety, and grief and the losses that come along with illness, and also doing fun things, making memories of this period of time so that you can go back on it, reflect on it someday, and understand what you went through.
Gotcha.
They also do a lot of, we'll talk a little bit more, but they do a lot of legacy work. So things that will help the child kind of, make their mark on the world. If they survive their cancer, wonderful. That legacy work is really important. If they don't survive their cancer, they've done it. They know that they've done what they can do to let people know how they feel about them and what was important to them, and then their families have that to take away.
Gotcha.
Yeah.
Thank you.
Yeah.
And we'll take just another minute or so to allow our audience to submit any questions. When you were showing that very colorful graph, I thought about patient-reported outcomes. And we've had Dr. Bosch and others talk about that. Is there work being done with pediatric patients around patient-reported outcomes?
Lots. Oh, yeah, tons of work. In fact, Joanne Wolf's group in Boston has been doing a study called PD Quest, where they're it's evolved because technology is evolving, but they're using direct feedback from patients about their symptoms to providers, and they're looking at how the oncology team responds, how the palliative care team responds, trying to make sure that feedback is given quickly and that can be acted upon quickly, and looking at whether symptoms are better managed, whether children feel more empowered, whether they feel like they have more tools to manage their symptoms, whether it's medication management or other non-pharmacologic treatments.
Great.
That's just one example of many, but it's pretty great work, and I hope that it'll be something, and certainly falls in line with some of Dr. Bash's work that he's talked about in adults as well.
Good.
Yeah.
Well, glad to hear it. Well, I'm going to hold on to the rest of my questions, and if we don't have other questions at the end, I'll save it I'll save those for that time. But let's go ahead and move on to the second part of your presentation.
All right. Okay, so I'm showing this slide again just to remind you that our plan is to look at palliative care at different stages of childhood cancer, kind of across the continuum. So I'm going to tell you about William. William is not actually a real person. He's kind of a conglomeration of lots of different teenage boys who we've worked with over the years. So he's a 16-year-old who's an avid soccer player and singer. He's very social. He loves being a 10th grader, loves sophomore year. He's the middle child in a family with 3 boys, and his parents are married. He sees a pediatrician because he's been having worsening leg pain over a period of 2 or 3 weeks, possibly a little longer, but 2 to 3 weeks is the time frame in which he's been complaining about it to his parents. It's starting to limit his ability to play soccer. The pediatrician is concerned. It gets an x-ray, which unfortunately shows a tumor in the femur, which is the long bone of the upper portion of the leg. He is ultimately diagnosed with osteosarcoma, which is a malignant bone tumor, and a plan is made to treat him with surgery and chemotherapy. So this is really tough, right? This is this active, vibrant guy, very busy sophomore, and his mom says, he doesn't really deal well with not being able to do what he wants to do. He's very driven. We need help. We need some help navigating choices. This is going to be devastating to him. I don't know if he'll find his voice. How can we involve him in decision making? How can we support him through all the changes that are happening in his life? So thinking about, for William, I'd like to look at those kind of 4 themes: communication, symptoms, goals, and decisions at each stage. And I guess this slide is a little bit of giveaway that we'll be talking about William at end of life. So unfortunately, this story doesn't involve a child who survives their illness, but we can pause at any of these stages to understand what the role of palliative care is. So at the time of diagnosis. So when we think about those elements of palliative care, so communication, really the role, the key things in palliative care at this point are to keep the door open for more communication and address any gaps in knowledge from what the patient and family are told at the time of diagnosis. So what we did was to offer William and his parents the opportunity to share what they learned from the oncology team. And of course, their takeaway may be very different from what the conversation sounded like to a bystander who maybe wasn't so emotionally invested in the case. So figure out what the gaps are and make sure that we can get the team to go back and help with any gaps in understanding. Symptoms. At this point, we want to assess physical and emotional symptoms associated with the cancer diagnosis and address patient and caregiver coping and grief. For William, we reinforced education about the symptoms of his particular cancer and also the side effects of therapies. That the oncology team did a spectacular job laying out for him and his family, and also talking about the treatments that would be offered. We also named the fact that there was a lot of grief and loss that was associated with this diagnosis and kind of made room for them to talk about this. And we offered connection to additional resources. Those brothers of his were having a really hard time. And the parents were as well. We knew that William would have access to lots of resources through his oncology team, and we wanted to make sure that the family was taken care of. Goals. Early at the time of diagnosis, we're thinking about introducing the concept of goals of care. What are we hoping for? What are we worried about? What are we concerned about? What are a person's goals within the context of kind of who they are when it comes to facing this serious illness? So we explored William's goals and hopes for his cancer treatment and for his future, and he didn't say a whole lot. Most teenage boys don't. His big goal was to not have cancer and to not be dealing with this, but unfortunately he knew that he was. We also addressed goals for family function kind of entering into treatment, because this is a big upheaval. They didn't live across the street from the cancer center. He was going to be hospitalized for surgery for several rounds of chemotherapy. He would come to clinic very often when he wasn't in the hospital. Somebody needed to care for the family. Parents need to think about what they're going to do with their employment while they're caring for a child who's sick. For some of our families, this is really their biggest worry, is how will we survive? How will we pay for food? How will we pay for parking at the hospital and have our lives uprooted? Decisions at the time of diagnosis. Really, basically at this point, we're kind of, again, it's not a time when there necessarily are a ton of choices to be made. We're going to treat or we're not going to treat is basically the choice. And of course, in this case, treatment would be the typical choice. We introduce frameworks for decision making. So really what that means is we discuss the approach to decision making with William and his family, how to involve teens in making choices. What do we do when different people in the family have different opinions, and we have some tools that we like to introduce to kids and families at this stage that can be helpful just in kind of facilitating their approach to decision making. So William underwent surgery and his recovery went very well, and he starts chemotherapy. So now we're in active treatment phase. So at this stage, when we think about communication in palliative care, our goals are to really address kind of learning a new language of medicalese and cancerese, and also a new way of life, right? There are a lot of changes. So we want to just have an open dialogue about this, and we want to be able to think about how the child and family communicate with multiple providers. It can be extremely overwhelming, all the people involved in care. How do we ensure that we're getting information in the way that we like to receive it? So we helped identify and address gaps in knowledge at this point around like just terminology and plans and what does it mean? And really the knowledge gaps in kind of like the changes in life, right? Like, how will we handle being hospitalized for such a long time and being out of activities in school? We encouraged William to share with providers kind of what he wanted to hear and what he wanted to know. And we really encouraged his parents to give him some flexibility. He's 16, so he's pretty savvy, but he's also a kid and relies and defers to his parents a lot of the time. He wasn't sure that he always wanted to know every detail. As far as symptoms, we continue to address physical symptoms related to cancer and therapies. We also address emotional response to illness, treatments, and life changes. For William, we made recommendations to the oncology team for treating pain, nausea, poor appetite, and fatigue because he struggled with all of those things. So we collaborated in this. We made space for discussion of the impact of illness. Some people want to talk about this, some people don't, but we named that it's okay to do that. And we encouraged continued engagement in emotional support for William, for his parents, and for his siblings to ensure that their worries and concerns were being addressed. Sometimes it's best to do that on their own and not in front of the rest of the family. So having them have people who they can go to for support, whether or not they're professional mental health providers, professional counselors, really having people that they can rely on. Goals in active treatment, really we have to re-examine them, right, within the context of basically gaining experience with illness. So now that we know more about this cancer and what treatment is like, what are we hoping for? What are we worried about? For William, really, we identified some realistic short-term goals because for him, he really wanted his symptoms managed, but he didn't want to be knocked out with medication. So he wanted medication, but he didn't want medication. He wanted to be physically active, but he was still healing from surgery. We talked about ways to alter his plans, just his life day-to-day plans without, missing out on everything. So still doing things that he enjoyed when he could, but how he could participate from afar as a kid in things that he couldn't do because he wasn't feeling well enough or because he was in the hospital. And then decisions. Ongoing support for decision making is really critical at this phase, even though it feels, again, like there aren't a lot of decisions early in active treatment. More choices do emerge. And William started to have more opinions, and we really wanted to work with him on ways to find his voice. This takes work with parents too, or caregivers, because kids they're getting older as they're going through treatment, and they're learning and they're gaining experience, and they are having more opinions, and they do sometimes want those to be heard. Sometimes they actually kind of retreat, and we worry that we're not hearing their voices, and so we try to help figure out how they want to be participating in decision making. So William had a difficult course with several complications and side effects of chemotherapy, but he did achieve remission. He regained his strength. He returned to school full time. He began modified sports activities and choir practice. He started dating, which was really exciting for him. And he started his senior year of high school. So there's a lot of time lapse here, right? And he has had the experience of being very sick. He's had the experience of having very good quality of life and kind of almost returning to normal. He then unfortunately developed some back and chest pain and was reluctant to tell his parents until the pain was severe and he had difficulty breathing. And this is really common, right? Because if we feel things that we've felt before that were associated with bad things, we would rather deny that they're happening. And that's very common for anybody, especially common for adolescents. Diagnostic testing revealed a relapse with metastatic disease. And William's oncologist suggested more surgery and chemotherapy and possibly a clinical trial because he was a little bit worried about the extent of his disease progression and also the challenges that he'd had with some of the chemotherapy that he'd previously used. So now we're at disease progression, right? We're at that kind of peaks and valleys phase. So here our symptoms are worsening and our treatments are intensifying. And here's where palliative care needs to intensify again. So as far as communication, this is a time when we need to be really having discussions about disease progression and prognosis. It's important that if we're asking people to make complicated decisions, they have the information that they need in order to do that. We, at this stage, address concerns about further loss of function and also about dying from cancer because that is what people are worried about, of course, when they relapse. So for William, we offered for him and his parents to share what they learned from the oncologist, both together and separately. We allowed William some time, just one-on-one, to talk if he wanted to, and his oncologist did the same thing. And it was especially important because he was about to turn 18, right? So technically an adult. We encouraged him to share his concerns with someone he trusted, and who that person was had kind of changed in the time frame because he was getting older, and the people who he leaned on in his life was changing. As far as symptoms, at this stage you want to address new physical symptoms. We also want to address patients reliving old experiences. That can be a really tricky part of this. So those symptoms bring back a lot of memories, and people can have anticipatory symptoms. A lot of people who've had chemotherapy, who are facing chemotherapy again, have really bad nausea before they even start their chemotherapy because they know how nauseated it can make them. And there's some new symptom experiences that come along with relapse as well. The shortness of breath was because of metastases and fluid in his lungs that he had not had at the time of his primary tumor. At this point, you also, of course, want to address the emotional burden for patients and families. So for William, we addressed concerns about new symptoms, and we used some of his previous illness experience to help guide recommendations to the team, right? He knew what had worked for his nausea before and what hadn't. He knew what his side effects were of certain things. He kind of knew what he was willing to sacrifice in terms of, lots of things in order to be as comfortable as he could be, and knew what he wasn't willing to do. We also encouraged re-engagement with other supports, both for William and for his entire family. Goals at this stage, really we're exploring goals of care in a totally different context, right? In the face of an illness that we're worried may not be curable. So we explored William's shifting goals and hopes for his cancer treatment in his future, and also his parents' goals. And we did it together and separately, which was really because he was turning 18, and also because it's important to allow people to express their opinions kind of in that safety net of not having to be in front of the loved one who's most invested and concerned. Decisions at this stage can get really complicated. We explored risks and benefits of treatment options, and we address advanced care planning, which is planning ahead for future medical care. That can be a lot of different things. So thinking ahead about the kinds of treatments that feel acceptable or not acceptable to you based on your experience. Thinking about the kinds of treatments that you would or wouldn't want if you became so ill that you couldn't speak for yourself. For William, we acted as a third party, basically to help him and his family think through options and also kind of negotiate a little bit with their differing opinions, because they were different at this stage. William had a big illness experience, and he had a lot of opinions about what he wanted and what he didn't want. And he was a little more willing to accept less intensive or aggressive cancer therapy because he was worried about the side effects, which had been really troublesome for him before. His parents weren't sure that he understood the potential implications of that. We encouraged advanced care planning and creation of advanced directives. So for him turning 18, it was important that he designate a decision maker should he be unable to make decisions for himself, a healthcare proxy or power of attorney. And we encouraged legacy work. So again, thinking about, who am I, what's my mark I'm making on this world, and how do I want to be remembered if I don't survive this illness? So William underwent chemotherapy. These were really his parents' wishes. He really did not want to do IV chemotherapy again, but he was willing to do it for his mom and dad. He had to stop early because his nausea was so severe and did not respond to medical management or behavioral interventions. We knew that anxiety and anticipation of symptoms were a big issue for him. He did have some response to chemotherapy, but then unfortunately more disease progression. And he and his parents again felt differently about ongoing cancer-directed therapies. But they agreed after lots of thought on oral chemotherapy and to try some radiation. William said at that point, really, my goals are to go to school, to spend time with my friends and my girlfriend. I want to sing in the choir concert this spring. I want to go to baseball and soccer games. I want to graduate from high school. And despite how sick he was and how many visits he needed to do the radiation and to come to his oncology clinic, to see his doctors and nurses, he did a lot of those things because that's what kids do, right? They live. And he was very determined not to miss out on those important activities. Unfortunately, though, his cancer continued to progress, and his oncologist at that point recommended no further cancer-directed therapies. So we're going to talk about William at end of life. So palliative care at this stage continues to be very important and changes and intensifies in many ways. So as far as communication, our goals are to promote communication, again, about prognosis and the inevitability of death so that people can plan. We like to share with parents, mostly parents, I say, because we work with a lot of kids who aren't participating in decision making, that we want people to know, to be prepared for what they can prepare for, if that's what they'd like to do. We also explore options for end-of-life care at this stage. Where do people want to be for their final days, knowing that it's difficult to predict when someone will die? So for William, we facilitated conversations and helped the oncologist choose words that emphasized active ongoing care, as opposed to we could try more chemotherapy or we could do nothing. We talked about, we're going to continue to treat you very actively for your symptoms. We're going to focus on comfort and quality of life, and allowing, again, William to share what was important to him. We introduced hospice, which he and his family opted to pursue in the home setting. We'll talk more about hospice in a minute. Symptoms at this stage, again, treating physical and emotional symptoms is critical, and addressing the emotional needs of the patient and family. So ongoing work with the oncology team to manage symptoms. This is a phase where we want to prepare people, again, so we prepared William and his family for managing symptom crises and other potential emergencies that we see in advanced cancer, so that they wouldn't be surprised and shocked, and that they would have the tools that they needed in order to treat symptoms. We also encouraged ongoing grief work and legacy work. Goals at this stage were really, again, identifying hopes and goals now in the context of anticipated death. So for William, we discussed quality of life. We discussed living well for the time that William had to live, and what did that mean to him. In decisions, here is a time when we do further advanced care planning, often documenting wishes, documenting advanced directives. So we facilitated the documentation, the conversations around this, providing appropriate tools and kind of discussing treatment options along with the oncology team, and importantly also communicated that care plan to his hospice providers, who will continue those conversations in the comfort of his home when needed. So William lived for several weeks after discharge home from the hospital during his final stay. He maintained contact with his oncology and palliative care teams, so we don't disappear. Oncology teams don't abandon their patients. Palliative care teams don't abandon their patients. We're still available. Hospice worked with hospital-based teams, that are oncology and palliative care teams, to treat his pain and other symptoms. This is what they do, but they want to be collaborative, and we work together. They provided a lot of emotional and spiritual support for William and his family, and ultimately he died peacefully at home. Hospice then provided bereavement support and resources to the family after William's death, and this included some resources for kind of the community around William, right, because he was a high school student who didn't survive to graduation, and then his community around him was very affected by his death. The family, not long after his death, returned to the hospital to visit the teams and to share stories from his final days at home, and also discuss a possible legacy project, which is something they dreamed up with their hospice providers that William wanted to do to kind of give back to the hospital and to help support other kids who are going through cancer therapy. And this is something that a lot of people do. It's pretty remarkable. So that's William, and I wanted to just give you a word before we close on hospice for children with cancer. So hospice is a really small portion of this, even though a lot of people equate palliative care and hospice. Hospice really falls under the umbrella of palliative care, but palliative care, as you can see, is broader. So hospice is a model for quality, compassionate care for people with life-limiting illnesses who are expected not to survive longer than about 6 months. It's also an insurance benefit, right? So insurance pays for hospice care. For treatments that are related to the diagnosis that someone is that leads to admission to hospice. It's focused on quality of life and achieving individualized goals, and it's provided by a multidisciplinary team, again, that includes medical, psychosocial, and spiritual care providers. Hospice care can be delivered at home or in inpatient care centers like hospice homes, and trained volunteers really support in-home care and also the inpatient-based care. Grief and bereavement support are offered to survivors, and that takes many forms. And importantly, children under the age of 21 are also eligible for concurrent care. We mentioned concurrent care in the context of goals and symptom management, but concurrent care in this case is that a child under the age of 21 can receive medical therapies that are intended to cure or restore health while also receiving hospice care. So it's pretty incredible, and of course we wish that adults have that same benefit. So thinking about the transition to hospice, what do our palliative care teams do to support that transition? So we often like to introduce hospice to children and families. We have team members who have experience providing hospice care, can really speak to what hospice is and why someone might choose hospice care, even if they're having trouble kind of accepting or thinking through the fact that they're likely going to die from their disease. We help establish connections with hospice agencies and collaborate with other psychosocial providers in the hospital, like social workers, but also case managers, to support the family kind of in their choice of agencies when choices are available. We provide medical and psychosocial information about the child to the accepting hospice providers because we want them to know what they're getting themselves into. Also want the families to kind of know who's on the receiving end, and the more communication, the more we can tell them. In fact, many hospice agencies will send a representative to the hospital to have that conversation with the patient and family in person so that everyone can get to know each other up front. We also assist the oncology team with planning for hospital discharge. So we think about what medications do we need for symptom management, what kind of equipment will support comfort and function at home, and let's develop and document some emergency care plans for the family for emergency symptom management and crises that can occur, and then communicate those to the hospice providers who can then work on further developing those plans if needed. And then, like I said before, we remain a resource to hospice providers because we want to make sure that we're all communicating. Pediatric hospice is not that common, and there are a lot of hospice agencies who really only care for adults with an occasional pediatric patient, and they really look to pediatric providers for additional support for a lot of the aspects of care, and then, of course, they're experts in end-of-life care. So just kind of in summary, palliative care for children with cancer, a few takeaway points. Palliative care prevents, identifies, and treats suffering in individuals with serious illnesses and their families. It's appropriate at any stage of the illness and can be provided along with treatments directed at controlling and curing disease. And partnerships among children with cancer, their families, their healthcare providers, and other supports are really essential to providing quality palliative care. And I think that's it. And I've listed our some contact information or the website for our supportive care team that is part of of course, the UNC Children's Hospital.
Great. Dr. Dellon, thank you so much. So now we come back to our Q&A. So please go ahead and submit those questions to Dr. Dellon now, and we'll take those at this time. I did mention I had a couple that remaining and a new one or two as well. Talking about fears of death, you mentioned that really comes up at the progression stage, and I wondered, does that get introduced at all at the diagnosis or treatment stages as well? Because I can imagine that anyone hearing the word cancer, it's impossible not to have death enter into this, and how do you raise that and provide a safe forum for a child or an adolescent to talk about that?
That's right. That's a great question, and I didn't intend to mean that it doesn't come up until then.
Sure.
It typically, right, is the greatest fear that people have at the time of diagnosis, right? My child won't survive this cancer. But how we bring it up and when we bring it up, from the palliative care provider perspective might differ from the oncologist perspective, right? Sure. So at that initial visit, when the cancer diagnosis is being discussed, survival statistics are usually shared as well. Everybody's styles are different. Some people ask if patients what they want to know, and some just share information in a fairly kind of standardized way to make sure people have all the available information. So we get brave and we try to ask those hard questions, right? What are you most worried about?
Yeah.
And I think that it's basically a persistent fear of many people, even through when they're in remission, right? Sure. And that fear kind of diminishes with time when someone's doing well, thankfully. But when it comes up again, it's really important to make space for people to share their fears. We run into situations where parents don't want their children to know that they're dying. Now we've talked about an adolescent. We take care of kids of lots of different ages. Some, through child development, have varying concepts of death, right? And understanding of what death is and that it's final and all of those things happen normally through development. So if we're going to be addressing concerns about death and dying, we want to do it in a developmentally appropriate way, and we want to use the language of the family, right? We want to facilitate conversations. We don't want to force conversations. Yeah. When parents are very reluctant to tell their child that their child is dying, a lot of the work we do is really centered on what do you think your child knows about their illness? And really, kids know an awful lot more than we give them credit for. And often it's really just about talking through how will I respond when my child asks me that. Or we also know that kids protect their parents. So do you think it's possible that your child is worried about dying, but they're afraid to say it to you? If that were the case, would it be important to you that your child had the opportunity to express their fears? Can we help you address the elephant in the room? Right. And that's a lot of the work that we do. And we call on those amazing, developmental behavioral specialists, our psychologists, our child life specialists, to help facilitate conversations. We often find, too, that kids really bond with certain people who are part of their cancer care. So it might be a nurse in the hospital or, somebody in the clinic who's really made an impact on them, and they're a safe person to have there for those conversations.
Well, thank you. And I guess tying in with that and talking about the parents, what does it look like when you're negotiating those situations where the treatment desires of the patient, of the child or adolescent, and the parents are different, and what does that look like in terms of those negotiations?
It can be tough, right? I mean, it's not usually as tough as the stories that make the news,
right?
Right? But it's really about trying to understand a family's context, really trying to understand kind of what their values are and what the roles of the different family members are, and why. How we can sort of come together. They're usually, the biggest barriers there usually are just fears of dying, right? So if a child wants less aggressive treatment, the parent worries that they will always regret choosing that treatment if the child doesn't survive. Right. But they don't want to say that to the child, right? So it often looks like getting to a very hard but very important conversation. And that can take place in lots of different ways. Sometimes it's the whole family. Sometimes it's a team member spending time going back and forth between parties and helping them come together, which they often do on their own, before we get to that point. Yeah.
Tough work, really important work. Tough.
Yeah.
Well, we did have a comment. Thank you. I appreciate the message being communicated that palliative care can be associated with living well rather than simply end of life.
Yeah, absolutely. That's so important. And it's something that every day in our work run into. We have doctors who consult us for their patients and say, it might be a little too early, and you hear the child's story. It's like, no, it's actually pretty late. So, this is a child that's having a lot of symptoms or a family that's in a lot of distress. And what can we do to try to help? How can we partner together to help this child live as well as they can live? And I think that's a message that's just tough. I mean, like societally, we don't understand palliative care. We don't even understand it in the healthcare setting a lot of the time.
I was going to say, I think there's a misconception about the difference between palliative care and hospice care. In the broadly, do you think that exists even amongst clinicians?
Oh, absolutely. Yeah, it's hard, right? We want our patients to do well. We want them to defy the odds. Hospice for children is really actually quite different in a lot of ways than hospice from adults. And there are a lot of children. We want to introduce it early. We don't want a child and family to meet a hospice team in the last 48 to 72 hours of life. We want relationships to be established. We want people to have the benefits of hospice for a long, long time. So it's really a lot of it is in how you introduce it, and just, being honest, and we know this is hard to talk about this stuff, but let me help you understand what it is that, the role of our team and really what it is that, how it is that we might be able to help you.
Right.
Yeah.
Well, thank you. This has been tremendously informative. Thank you to our audience for being here today, and thank you for the comment. Just a few closing remarks. We want to make sure that you provide a survey to Dr. Dellon and to our team, so you can go to unccn.org/evaluation and click on the lecture evaluation survey. Please just take a minute or two to do that. You can also go to unccn.org, go to community education, click on evaluation, and you'll find the survey there. So we hope you will take time to do that. Remember, we have our learning portal, learn.unccn.org. You can get a free account, and that's one of several places that you can go back and view this lecture and many other lectures, over 200. Next Lunch and Learn lecture, Community Lunch and Learn lecture, will be on May 18th, 2018 at noon. Skincare, what's the difference between melanoma and less worrisome skin cancers, with Dr. David O'Lilla. So we hope you'll be here for that. We want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center and the UCRF Fund. We want to thank Mary King, Veneranda Obore, and John Powell for their tireless work to make this and the many other lectures that we provide possible. Again, unccn.org. We're on Facebook, Twitter, we're on Instagram, we're on Pinterest, and several other social media forums as well. So thank you for being here today. We look forward to seeing you at future lectures. Dr. Dellon, thank you. This has been great.
Thank you.